Hi, welcome everyone back. Okay, we are going to S-190. So little back story on this. We voted this out of our committee 1100, I think it was. I really should write that down since I'm the bill reporter. And after we voted it out of this committee, and it is now in Ways and Means, it's been committed to Ways and Means. There were concerns, I don't know if you remember at the very end, there were concerns about, whether this was inclusive or separate from hospital budget orders. I want to remind everybody, Green Mountain Care Board, in their authority, approves hospital budgets. They've been doing this for many, many years. Rulemaking, there is a process for this whole thing that takes place. And it's sort of as looking at the language and trying to change the language to reassure some of the stakeholders. It sort of became apparent that the legislature was inserting themselves into the already established process of hospital budget review and was putting parameters on that. And frankly, I became very, very uncomfortable with that because that is not our job. We have given this authority to the Green Mountain Care Board, and we should not be inserting ourselves. And, we were sitting here and we were trying to come up with these like percentages and numbers, and everybody was going back and forth. And it's like, wait a minute, that is not what the legislature does. The original premise of this bill was that in Act 68, the legislature tasked the Green Mountain Care Board with moving forward on reference-based pricing through starting with hospital year 27. That's what we put in statute. They are going through that process. However, the rulemaking process takes a long time, which meant that they were not able to actually start implementing reference-based pricing in hospital budget year fiscal 27. So the original origin and point of this bill was really giving the Green Mountain Care Board the authority to begin reference-based pricing sort of in this year, because the legislature can do that authority. We don't set hospital budgets, but we do give authority to the Green Mountain Care Board to set reference-based pricing. So therefore, Jen has an amendment that I am proposing, and I am looking for anybody else who would like to sign on to that amendment. And she can walk through the amendment. And I think, frankly, it simplifies the bill significantly and us doing the job we're supposed to be doing, and entrusts that all the other processes that are already in statute and already working continue working absent our picking them up. Thanks, Jen. Want to take it away from there?
Jen Carby, Office of Legislative Counsel, and it's up on the screen. It is posted on the webpage. So this is an amendment, as the chair said, from Representative Black, and you can add others if people want to be on it. And she moves that the report of the Committee on Healthcare be amended as follows. There's a few instances, but they are all on targeting that same issue. So first, it would strike out Section 2 of the bill, which was amending 18 VSA Chapter 221, Subchapter 7, which is the hospital budget review subchapter, and instead just putting in, because we're only dealing with one fiscal year, putting in a session law section, so not putting this in statute, but just in the white books and the action resolves. That would be limitations on hospital reimbursements for qualified health benefit plans and plans covering school employees for hospital fiscal year 2027. In the definitions, it deletes the definition of hospital entirely. It is not, because we're not limiting it to certain types of hospitals. It would apply to any hospital. Medicare adjusted base rate is a definition that was being added in a different piece of the subchapter, so I'm putting it in here. And then we have our definitions that we looked at before for qualified health benefit plan, registered carrier, which is an exchange plan carrier, and school employee. So this is instead of saying in establishing fiscal year 2027 hospital budgets, the board can direct an amount equal to 3.5% of hospitals' combined commercial net patient revenue toward the reductions for the qualified health benefit plans and the VHI plans. It would instead say, notwithstanding any provision of 18 BSA 9375B1A, which is what directs the Green Mountain Care Board to do rulemaking for rate setting. So notwithstanding any of that, because they're in that process, but they don't have a rule yet. For hospital fiscal year 2027, the board may, being a little more specific here, order as part of their order authority, may order hospitals to reduce their commercial reimbursement rates for qualified health benefit plans and for health benefit plans offered to school employees by Health Benefit Association. So that's VHI, based on a percentage of the Medicare adjusted base rate determined by the board for each item provided and service delivered in Vermont to enrollees in these plans. So it is not specific on an amount. It is specific on that the board can order hospitals to reduce their rates to the QHPs and VHI plans. Then it takes out the language about FY 27 and 28 and 29 hospital budgets. So it does not address those. And the legislature can address those next year if you need, or there may be rules in place at that point. It keeps the language directing the carriers and VHI not to reimburse or agree to reimburse a hospital more than a percentage of the Medicare adjusted base rate that the Green Mountain Care Board specifies. And keeps language saying, if it's not fee for service, then make sure it's working with those rates. Still prohibits hospitals from balance billing. Still says to the extent that a hospital is required by the board's budget order to reduce its commercial reimbursement rates by amounts greater than what is achieved through that subsection B, then the hospital would target its rates that are greater than 500% of the Medicare adjusted base rate or otherwise highest in relation to Medicare. It removes the language specifically saying a hospital can increase the commercial reimbursement rates for other service lines as long as it's compliant with the total budget ordered for the hospital, because this is largely separating from budget orders specifically, and then just changing the subsection reference in what was G, now F, directing the Green Mountain Care Board and DFR to make sure that the premiums for the QHPs and the VHI plans reflect the limitations. The second instance of amendment strikes section 3, which was the change in the outpatient prescription drug cap from 120% of average sales price to 130% of average sales price. So that provision would come out of the bill entirely, and that means the cap would stay at 120%. And then third is taking out the effective date section and putting it back in, restoring just the act takes effect on passage, because section 3 in the bill you passed out had its own special effective date to deal with the average sales price issue. So we don't need that anymore. We'll just put it back in as put back on.
And as you were going through it, I was reminded that, this bill came from the Senate and been on record many, many times. We were very aggressive in Act 68. The legislature was very aggressive in that we wanted reference-based pricing to start in hospital budget year FY 27, which starts October of 26. And the chair of Senate Health and Welfare has been very open and on the record as saying, we said 27, she wants it to start now, and that committee says we want it to start now. And that is the impetus of this bill. And I think this amendment goes to that intent. It goes to the intent of what Act 68 was. And it. That's what it does. And unfortunately, because of rulemaking, we wouldn't be able to do that. So this puts back in the intent of what the legislature is doing. So any thoughts, any questions? I guess I'll ask if anyone wants to sign on to it with me. And then I'll have to straw poll it.
I just need clarification. So there are those instances of amendment which affect those specific sections. The remainder of the bill remains intact.
Right.
So what sections remain intact, just so we get that on the record?
1, 3, 4, 5, 6, 7, 8, 9.
Basically, everything.
All the other
Except
things
what's
that
being
we-
amended.
What about 9? So 9's still in, because there was that,
What, I don't,
yeah, that's
don't
the critical
remember.
access hospital, Medicare, outpatient, primary.
Yes.
yep,
That's
still,
Still in there.
Okay, so that dynamic went away, or, I mean, it was 130, whatever. Not think about it. When, that was that negotiation. Never mind.
Oh, that was the ASP. Right. And
We changed that number. That was some
section 3 is,
dialogue. All right, I can let it go.
okay, I'm not familiar with the connection between section 3 and section 9.
I don't think there is.
Okay.
There was a connection with section 3 with section 2.
Right.
So,
Yes.
which is why it's been deleted.
Exactly. Section 3 was in the bill, changing that max the cap on the average sales price because of the financial implications of section 2 as it came out of this committee. And so since section 2 would be changing, section 3 is no longer tied, no longer necessary to achieve that specific goal.
Thank you. Yeah, I just want to understand, does this apply to all hospitals then?
Yes, it applies to the board's ability to set, to make orders for all hospitals.
Mine's just on process, so I'm just trying to understand how this came back, and I absolutely get, I'm willing to sign on to the amendment, because I get it, believe it or not. My question is the process, so
We voted the bill out. The bill is in House Ways and Means. The bill has to also go to appropriations. I will present my amendment to Ways and Means.
okay,
For their consideration at the same time that they're considering the underlying bill as passed. And then I will do the same thing in House Appropriations. And then when I report the bill on the floor, I will report the bill. They will do their committee reports, and then I will report the amendment.
so you already reported the bill, and nothing came back, like, you just.
We have not reported the bill.
Oh, that's right.
Yeah.
Okay, all right, I just didn't understand the process.
I may need to change the lead-in language slightly if other committees amend the bill in order to reflect what other committees have amended. the bill.
Madam Chair, we do have a time crunch here
Yes.
that we have to leave. Can we get to the straw poll?
Yeah, I want to give Val a chance to ask her question here. real quickly.
Well, I don't have a question. I would just, like to see how the bill you passed last year unfolds before we layer another bill on top of it. I mean, I think, I understand there's a rush. I feel like the healthcare is in a crisis. I understand my position in this house and how little I know. I don't like rushing. I don't like giving an unknown full authority to, in all due respect, Green Mountain Care Board. I think it's wide open, super intelligent. I respect them completely. My vote's still no.
Okay. I want to make it clear that we're not giving them any more authority. This is authority they have.
Yeah.
And have had for many, many years, other than the reference-based pricing, which we gave them that authority last year.
Instead of changing your authority, how would you summarize what we're doing?
What we're doing is we are doing legislative intent of what we did last year, which was said reference-based pricing will start in 2027. And we are allowing that to go forward.
And I will, yeah, I'm sorry, I'll just add, one of the main things we talk about around this table is affordability and this ability that to start reference-based pricing early will help with that, to be able to direct it to, I don't know what section that's in.
QHP and VHI.
UHP and VI will have a direct effect on what Vermonters pay for premiums. And I think is super important. So I fully support this amendment. Thank you.
I just feel like we don't have support of everyone behind this bill. And that's what I rely on.
I'm willing to sign on as a sponsor.
Yeah, I would like to sign on too. I mean, what I like about it is everyone seems to agree reference-based pricing is the way to go, will be effective. And here we are, getting a start on it in the way we intended. It's really happy to get started. I like the amendment. Thank you.
So the only reference that was made that the Green Mountain Care Board has the authority to do this already was when the chair said we can do anything we want in my conversation and, you know, set rates, whatever that were in here.
That's in hospital budget review. They have, yeah.
Yes, yes,
Yeah.
but that's where we're talking, and ultimately this is where this will end up. I'm disappointed there's no control over it could go down to 200%. The 350 and the 250 is gone. So I'm concerned about the viability of the hospital. Certainly, I'm concerned about the ratepayers. But I don't think this does enough to protect the hospitals, frankly.
I think what's important to remember, and what the chair has been saying, is that the Green Mountain Care Board has a lot of authority. They're the regulatory body over the hospitals. And they also do not want to see our system fail or hospitals fail. I've been in countless meetings with them. They've said it on record. They are doing what they can for this balance of hospitals, make sure we have access and affordability and quality at a price that Vermonters can actually then get the healthcare. And this is a step that can happen now to still achieve both. And I have full faith in the Green Mountain Care Board that they are not going to do something a hospital out of business.
We have had rural hospitals, critical access hospitals across this country close in droves. And the state of Vermont has not had one. And the Green Mountain Care Board is responsible for that.
And the hospitals.
And the hospitals.
For the good work they're doing.
The good work they're doing, but, you know, to say, you know, I often hear this argument that the Green Mountain Care Board is just gonna do things to hurt the hospitals, the very hospitals that they're trying to sustain. And I think in proof of what we have in the state of Vermont, that our hospitals have remained solvent, is evidence that the Green Mountain Care Board is doing, you know, the best they can towards that achievement. And you're right, I mean, you know, Lori's right, this delicate balance of also, you know, trying to have affordability in the insurance market. And I think when Dr. Leffler sat in front of us and told us that UVM is losing almost $500,000 a day. And it's not because of any of the rates that the Green Mountain Care Board has set, or the budget guidance, or the budget orders that the Green Mountain Care Board has set. He sat there and he said, utilization is down. And we are watching in real time, I believe, the effects of what happened on December 31st of 2024 that completely disrupted the QHP market. People cannot afford to actually use the insurance that they are paying tens of thousands of dollars for. And that, I think, is going to be one of the worst things for hospitals because they rely on utilization. And it's this delicate balancing act. And that's what the Green Mountain Care Board is trying to balance. So, you know, by not reducing premiums in the QHP market, because you think you're saving hospitals, that actually is what is hurting hospitals. When people can't afford to use their insurance, when they're on these high deductible, that's me.
Right, so I guess what I can't wrap my head around, because when I'm listening, I'm trying to listen and I'm breaking down emails and I could literally swim in the papers and trying to understand. I want to understand how my insurance premiums, husband and I, self-employed, $40,000 deductible, $2,200 a month. Like, so we're focusing on QHPs and Lehigh, and that's great. But I'm going to bring it up. I'm going to bring up that pass-through funding because everything that I've read makes it sound like even if it doesn't secure a lot of federal funding this year, as we roll, like we have to get that waiver in order for it to increase down the road. And then these savings will help somebody like me. Is that how it goes or not?
Lowering the rates that you pay right now is
Isn't that what
going to
has-
have an immediate impact on your premium. The 1332 waiver that DFR is talking about is a federal waiver that states can apply for. And if you remember, we put in budget language this year that the state of Vermont will apply to the federal government for a 1332 waiver and develop reinsurance. That is a completely separate issue. Their
But when do we
intention,
have to apply for that? Isn't it every 10 years?
no, we've never applied for it before.
The state has
So-
never applied for it.
So we are giving legislative authority for them to do that. And that's language that's in the budget. We did
There's
that
other
way back
waivers,
in-
yes, there's other waivers.
So this bill is
This doesn't
speeding
have
up
anything
Yeah.
to do with
what I
that.
did last year. So it's like Red Bull
No,
No,
on the bill you did last
this
year.
bill is actually enforcing what we did last year.
we did a lot of things last year too, so this is specifically related to the cost of hospital care. It's not, we did a lot of other things last year too. Like this is accelerating or maybe accelerating is the wrong word. Maybe it's like moving obstacles out of the way so that we can move forward with controlling the cost of hospital care, which will lower costs of premiums over time because a big reason why we pay a lot for healthcare is the cost of hospitals.
I want to speak to my hospital. I want to speak to everybody. I'm sorry, it's still no vote. I can't push this.
Okay.
We can keep talking
Yeah.
too.
Well,
Oh,
we have to leave.
Okay,
Yeah.
I'm taking a straw
Calling the
poll. So
question.
first of all, can I ask who would like to be on the amendment? And Daisy had indicated that she also wanted to be on that amendment. So Jen will get it. Oh, and Lori? Okay. So all those who find Representative Black et al.'s amendment favorable, please indicate by. Do I get to vote on my own amendment?
Yeah.
Okay, and unfavorable? 3.
4. Wait, did I miss someone?
Okay. We will go to 197. I'm gonna try to find some time this afternoon, or will we have breaks?
I can do something to cause us to have
The
a
air.
break.
Keep an eye on
Yeah.
your
Oh,
phone.
okay.
Thank you. And we can go offline.